not sure I would use that phraseology, but I'm going to talk about how to handle the ulnar nerve in the setting of distal humerus fractures. No, I'm just kidding. I'm going to talk about cubital tunnel syndrome in general. Now we'll see how we go forward here. Is it the green?
It's that big green arrow.
Big green arrow, there we go. So cubital tunnel syndrome, as we all know, symptoms, tingling and numbness, pinky and ring finger, some elbow pain in the area of the cubital tunnel, and loss of intrinsic muscle strength, and some cramping in the hand muscles. It's usually an insidious onset, but sometimes someone will show up in your office, and it just happened like a week ago, and they have motor and sensory deficit, and it's completely out. And you ask them, well, what happened? And sometimes they've been flying transatlantic, leaning on the armrest overnight, drinking a little bit, and they knock the ulnar nerve out completely. In that case, it will come back. You don't have to do anything, just try to keep the pressure off the ulnar nerve. Sometimes it goes out, and there's no prodrome of anything like that, and they didn't lean on it. And there are other things than compression that cause ulnar nerve neuropathy. We had a woman 2 months ago. Her ulnar nerve went out, and really couldn't explain it. It was just one day it was fine, the next day it was out, and then her other ulnar nerve started to go out. And you send these people to a neurologist because there are a lot of unusual nerve things like CIDP, autoimmune conditions that can affect the nerves. We got an MRI. Her whole ulnar nerve lit up from the wrist down up to the axilla. And she got IVIG and prednisone and got better. So you have to be careful. Years ago I got burned. I did an ulnar nerve release on someone with motor mostly findings, and then he called me about 2 months later, said I'm having some trouble breathing, and my other ulnar nerve is bad, and he had ALS. So it can present that way, so you got to be careful. So the anatomy of the cubital tunnel, this is a right elbow. The hand is up on the top left. That ME is the medial epicondyle, and the MIS is the medial intermuscular septum, and that's the ulnar nerve. Now, the things that compress the ulnar nerve, the arcade of Struthers is said to be a compressive problem. That usually hardly ever happens. The medial intermuscular septum, under normal circumstances, should never be a compressive problem unless you transpose the ulnar nerve. On the residence exams, that sometimes is an answer. That's a wrong answer. The MIS does not cause compression unless you transpose the ulnar nerve. The ligament of Osborn at the cubital tunnel, that's where the nerve compression usually occurs, as well as just distal to that at the FCU aponeurosis. And beyond that, there are sometimes some compressive bands, but very rare. Now, when you dissect these out and you find these little tiny things under the skin, everything that looks like a nerve is a nerve, okay? There are medial antebrachiocutaneous nerves that come proximally, the medial brachiocutaneous nerves proximally, rather the medial antebrachiocutaneous nerves distally. Now, someone with cubital tunnel syndrome should not present with numbness in the forearm over here. That is not the ulnar nerve. That's the medial brachial and antebrachiocutaneous nerves that come way off in the plexus. So if they have numbness on the forearm, there's something else going on. Make sure they don't have a Pancoast tumor, lung tumor, pressing on the medial cord of the brachial plexus. On exam, they're tender over the nerve. They may have a Tinel sign. The ulnar nerve starts to get a little freaky when they flex the elbow. And there's something called the scratch collapse test, which we'll talk about in just a second. They will have decreased sensation, pinky and the ring finger, maybe some decreased interosseous muscle strength, and decreased strength of the FDP to the small finger. There was a nice study done here. This was in Muscle and Nerve last year, and they looked at medial elbow pain alone, and did that correlate with cubital tunnel syndrome? And they did nerve tests, and they said, well, it doesn't. If you have predominantly medial elbow pain in the absence of sensory motor findings, it's probably not cubital tunnel syndrome. The scratch collapse test has been popularized by Susan McKinnon. You face the patient and you have them put their arms out and you say resist external rotation. You hold their arms on the side and they'll push out. They should have good strength of external rotation, assuming they didn't pop their rotator cuff. Then you scratch the inside of the elbow and again resist them, and lo and behold, you can break their external rotation very easily on the side that has cubital tunnel. Seems like a magic trick, but it actually can work. I don't use that. EMG, is it necessary for the diagnosis? A lot of people say no. I always get the EMG because some people with cubital tunnel are pretty freaky, and I want to know beforehand that they have it, because if they don't get better post-op and then we get an EMG and there are problems, we have no idea what we're dealing with, whether it got better or it got worse. So the conduction velocity usually should be greater than 50 meters per second across the elbow. The non-operative treatment, don't lean on the ulnar nerve. You have people typing all day, they're leaning on the edge of the desk. pressing on their ulnar nerve in the forearm, right on the edge of the table. That's going to cause numbness in the fingers. So you want to keep the elbow straight, don't lean on it. We give them splints to wear at night, and vitamin B6 probably is helpful if they don't take vitamin, if they're deficient in B6. A cubital tunnel splint can be placed either on the posterior side or the anterior side of the elbow, and there's very good evidence that this works. This is a study from 2009. They had 90% success in treating mild to moderate cubital tunnel with a night splint for 3 months and just not leaning on the ulnar nerve. Another recent study in 2013, this is from the Gelberman's group, and they found a 90% success without surgery by doing the same thing, by splinting at night and not leaning on the ulnar nerve and not keeping the elbow bent. And in their study, they had this orthosis that they used at nighttime. I've never used that, but that looks like a good option. What about corticosteroid injections? We inject the carpal tunnel. What about injecting the ulnar nerve? I've never injected the ulnar nerve, but this was a prospective randomized trial from the Netherlands, and what they found was they injected saline or cortisone, and there was no difference. About 30% of both group responded. Surgical options. The non-transposition methods include doing a medial epicondylectomy and doing a simple in situ release, which can neither be done open or endoscopically. And then there are various transposition methods: subcutaneous, submuscular, intramuscular, and variations. Dr. Rosenwasser has come up with an ingenious adipose flap, which is a method of transposing it subcutaneously, where you shell out a whole adipose flap and wrap it around the nerve. This can be very good in revision cases, especially. Why transpose the ulnar nerve? Well, a lot of people, and I'm sure many people in this audience, if you sleep with your elbow bent, your small finger and ring finger are going to be numb for a little while. That happens to me all the time. So when you bend the elbow, it puts tension on the nerve. So that makes sense to transpose it. Also, some people's ulnar nerve subluxates, and when they flex it up and down, it'll pop over the medial epicondyle, and transposing it eliminates that problem. Why not transpose? Well, you cause trauma to the nerve and the blood supply. The results, as you'll see, are equal to not transposing it. It's a smaller incision, and maybe you can always transpose it if it doesn't work. However, the results of revision ulnar nerve surgery are not as good as primary surgery. This was a really good study done in 2014 from Japan, where they looked at the effect of preserving the little blood vessels to the ulnar nerve. And in half the cases, they preserved them and transposed the ulnar nerve and looked at it with the laser Doppler. And in half the cases, they purposefully cut all the little nerve vascular branches to the ulnar nerve and transposed it. And intra-op, they showed better flow to the ulnar nerve in the cases where they preserved it, but it didn't matter clinically. There was no difference. But you'll hear anecdotally somebody that did an ulnar nerve transposition on an older person, diabetic, vasculopath, and the ulnar nerve went out completely post-operatively. So there are cases floating around out there where the ulnar nerve has gone out from transposing it. Where to put the ulnar nerve? Well, which method has been shown to be better? None. If you are doing a revision and it was subcutaneous, you might put it submuscular. If it was submuscular, you might put it subcutaneous. You probably do what was not done the first time. Why do it endoscopically? Well, if you feel that simple decompression is a reasonable pathway, then you can do it. It makes sense. The evidence, okay. Decompression alone versus transposition. There are at least several studies, many studies that show that this is equal. So simple decompression, you can make a small incision, cut the ligament of Osborne, cut the FCO aponeurosis. If you want, you can make a longer incision and cut everything else, but don't cut too much or it'll start to flip around. So the incision can be nearly as long as a transposition, and you cut everything that looks tight on top of the nerve, but not too much, because you don't want the nerve to start subluxating. Transposition is a transposition where we put it in the front of the elbow. Now, there are 4 prospective randomized clinical trials comparing simple in situ release to anterior or submuscular transposition. And the first one was backed by Nabhan from Germany in 2005. Subcutaneous transposition versus simple decompression, no difference. This is a prospective randomized study, and less complications in the simple release. They recommend simple decompression. Another study, also 2005, was a banner year for ulnar nerve studies. This is in neurosurgery. Simple decompression versus anterior submuscular transposition, no difference. Another study by Bartels, 2005, also in neurosurgery. Another one comparing subcutaneous transposition versus simple release. No difference, fewer complications to do an in situ. And finally, Biggs waited a year, and in 2006 reported on this one, which is a submuscular versus in situ release, no difference. So then come the analyses, and in 2007, Brent and Graham decided that it's probably best just to do a simple decompression based on their review of the literature. Is there any downside to simple decompression? Well, in 2009, Mansky and his group from St. Louis reported that about 7% of the ones that they did a simple release on needed a revision surgery. And a more recent 2017 larger study from Boston looked at the re-op rate of simple release, in situ release versus transposition, and the revision rate was, if I can read that there, was about 12% for ulnar nerve transposition and only 2.5% for in situ release. So the revision rate was much higher for the ones that were transposed. They also found that it was a higher rate of failure requiring another surgery if the patients had medical problems, such as diabetes or prior trauma to the area. There are three kinds of lies: damn lines, and meta-analyses. So this is a meta-analysis where they looked at all the studies done and they concluded that probably simple decompression was reasonable. This was Kevin Chung from Michigan reviewed everything, and after reviewing it, he concluded that he was going to change his practice and just become an in situ decompressor versus a transposer based on the literature. Susan McKinnon in 2009 felt that transposition is probably reasonable, but be careful if they're young because they might start to subluxate and that might potentially ruin your results. So what do you do about the ulnar nerve that starts to ride up on the medial epicondyle after you do a simple decompression? You release it, and then you start flexing and extending the elbow, and it looks like it's coming up a little bit on the medial epicondyle. This is an interesting take on that problem by Lou Lane from Long Island, where they used the fascial flap that we would normally use to secure the ulnar nerve anteriorly to the medial epicondyle, and they used it to secure it posteriorly to the medial epicondyle. So here's their ulnar nerve. The hand is down at the right of the screen, and that's the ulnar nerve in an hourglass configuration. I think the retractor is on one of the medial and brachiocutaneous nerves. So they take a fascial flap that you can see outlined with that rectangle, elevated proximally, and instead of flipping the ulnar nerve anterior, they use this to keep it in the back. And so here's that fascial flap being rotated from their article. There it is, and you want to make sure that you don't make it too tight or you can recreate the cubital tunnel syndrome. And this is a bird's eye view of it, showing the flap flipped over and securing the ulnar nerve and a lot of room available for it to move. Endoscopic is basically an in situ that's done via smaller incision. There's actually a case report of using using the endoscope to do an anterior transposition of the ulnar nerve. That's the only time I've seen that. That seems a little beyond the pale. But Tsuman Sai from Louisville first described in situ in 1995, and what he used was a glass tube. This was reported in Journal of Hand Surgery. And he used a glass tube with a little slit in it where you put it in and then you push it up and down and you take a little pusher knife and cut everything that looks tight on top of the ulnar nerve. And that's from that article. Maria Simenow, 2006, reported a slightly different method of doing it, but with also good results. Arthur Mirza came up with a scope technique of doing it, similar technique, different little scope. And then this is from the article showing how you can see the bands on top of the ulnar nerve and you can cut them. And then Ty Cobb has a popular device to release the ulnar nerve with an endoscope that has its own little obturator, and you put it in and carefully release everything that's tight on top of the ulnar nerve in that way. And he reported good results with this technique. And that's a view on the right from inside the scope looking at the ulnar nerve after it's been released with a small incision. There are a few problems with this technique. One is that hematoma can form when you are releasing the ulnar nerve in an open fashion. There are little tiny vessels that sometimes look tight that cross the ulnar nerve that you need to coagulate with a bipolar. When you're doing it endoscopically, you slice through those, so that can cause a hematoma. And so you have to be careful that that doesn't develop. This was a patient-rated outcome from Australia, Greg Bain, 2009, comparing endoscopic versus in situ release. And the outcomes were similar with less complications in the endoscopic group, except one of the endoscopic cases needed to go back to the OR for a hematoma. This is one from Neurosurgery 2010 on endoscopic decompression, where they found that it was safe. However, in patients that had a lot of fat around the elbow, they felt it might be difficult to identify the proper opening point, and maybe in large people you shouldn't do it. This was a prospective randomized double-blind study, I believe from Germany. And they didn't find a difference between the endoscopic and the open method, but their conclusion was the open decompression remains the procedure of choice at our institution. So it seems like they still favored the open in situ release. So what I used to do was subcutaneous transposition, and we used some kind of tissue to keep the nerve anterior. We would start moving them right away with the bandage on, and here it is, the nice long incision. Release the ulnar nerve, transpose it. You can see the little vessels still attached to the ulnar nerve, which is not that hard to keep that intact. And then important to preserve and don't injure the little branches of the medial brachicutaneous nerve that can cause painful neuromas, and transpose it, and that was good. But now I usually do an in situ release for all my primaries pretty much, unless they are subluxating prior to surgery. It's a little bit of a shorter incision, then we'll look at the ulnar nerve, make sure it doesn't subluxate. If it does, we'll do an anterior transposition. And for traumatic cases, as Emil said, it really doesn't matter, but I'll just, if it looks like the ulnar nerve is going to be riding on the hardware, obviously you don't want that to happen, so you're going to have to move it away from prominent hardware. Thank you very much.